Welcome to Grand Rounds today. Today it is my pleasure to introduce Chris Perrin. Chris is Emergency Management Coordinator at Mary Greeley Medical Center, and in addition to being an EMT, he's also an American Heart Association instructor, and he very graciously has accepted our invitation today to update us on the most recent ACLS guidelines. And please join me in welcoming Chris Perrin.
Thank you, Dr. Hallberg. I'm going to go ahead and give you an overview of advanced cardiac life support. They had a fairly significant, in their minds anyway, this is the Heart Association update in 2020, and they did a lot of things. The practice particulars, there was some tweaking. I'm not sure there was anything that was hugely overhauled, but we're going to go through that. This slide goes into far more in terms of background and preparation, but as Dr. Hallberg said, I've actually been around basic and advanced cardiac life support for a little over 43 years, an instructor since I think just 3 years or 4 years after ACLS actually was opened up from its initial physician-only course to allied healthcare providers, and been involved with it ever since. Lots of things to brag about, but probably not too much that's relevant there. Let's see. So let's get a definition up here. The Advanced Cardiac Life Support's continuing education program, a continuing education program. It's at its core is an evidence-based principles and practices for peri-arrest and cardiac arrest management of adults. And I'll probably spend more time on the cardiac arrest management of adults, but we'll share some information across the spectrum. And I do want to be somewhat agnostic in this, in that the Heart Association overwhelmingly sponsors the science behind it, but ACLS programming is offered by the Red Cross, by the American Safety and Health Institute, and then I'll have a slide or two to talk about a unique initiative that's been going on for about 11 or 12 years at the University of California, San Diego Health. They created a program called ART, and a corollary to it called BART that takes this on as well. So there's a couple of different variations, but the science that's predicated on is the same. This was scrolling through prior to my starting the program, but I'll just put this back up there, that my objectives today is really give you a basic understanding, or just a refresher, real quick refresher on the evidence evaluation and recommendation practices. How do they evaluate it? And then also talk a little bit about those updated recommendations and priorities. Again, primarily cardiac arrest management. And then as time allows, I want to talk about taking a priority-driven conceptual approach. I'll share some of what they've got, and then another one that I've found some success with for some folks that I'll let you take a peek at and see if it's helpful for you. So those are my objectives. When it says peace of mind, sorry for the bad pun, but I've kind of broken this down into a few slides each on the past of ACLS, talking a little bit about the problems of trying to move forward in the science processes, practical points, the performance itself of ACLS in the real world, the perfusion priorities that we take into that, and again, that it's framed in principles and practices. And then, as I mentioned, maybe another way of looking at it might be helpful to some people. And then even towards the end, a preview of some of the things that are going on right now, even in our area, that are kind of on the, maybe not the main core or the main body of ACLS, but certainly adheres to the tenets and might be part of the future science that's shared. So the past. So this slides might be a little bit busy. They're really for people that are less interested in hearing me talk and maybe want to look at some stuff, but there's a sequence of slides across the top as CPR has evolved over the years. And, just in the late 50s and early 60s, Dr. Safar and some colleagues published on this closed chest CPR. So CPR came into its own in the 50s and 60s. Defibrillation was in there as well. But ACLS, involving medications and a little bit more complex strategy, first came into being from what I can find in 1974. The first text came out in 75. And as I think I alluded to in my introduction, it was first really strictly for physicians, but then it was soon realized that, physicians don't run every aspect of ACLS, so need to broaden the continuing education program. And so first textbook in 75, and there have been a number of updates and iterations since then. This is kind of how it grew a lot in the early years in terms of adding a lot of medications and strategies. And then, about 20 years or so, they really kind of clamped down and said, let's look at really what does the evidence show. And in 5-year intervals, in between these intervals, they would gather information, review it, discuss it, and then present it on the or during the late months of the years that I've outlined here, 2000, 2005, and 10. And so really, starting about 20 years ago, it was starting to cull the herd or thin out some of those practices that weren't maybe as strongly evidence-based, and really strengthen the science and really look hard at what people were advocating to see how well it was evidenced. So sort of like the show Survivor, where today a number of the things that we started out, certainly in my practice many years ago, the Johnny and Roy syndrome in EMS, where we were flipping the caps off of some amps of bicarb and giving calcium and dextrose and beryllium. That's all been shelved, and it's a much leaner, evidence-based core that we see now. So let's look at that. As that happened, they look at the way they taught, the way that the science was gathered, and this is not from the Heart Association. This is from the Institute of Medicine. This came out in 2015 and is really, in my mind, I'm not sure how many people have seen this, but this Strategies to Improve Cardiac Arrest Survival was really a call out to everybody, internationally, in fact, that we've got to do better, that since the CPR, closed chest compressions, came out in the 60s, and then we started to track it just in terms of survival rates, we really weren't seeing much, certainly over in larger numbers and greater populations. There didn't seem to be a lot of improvements. So the challenge in 2015 is to really try to get more research sponsored, and also relook at how we've kind of institutionalized ACLS and maybe rethink it and maybe take some calculated risks in how it's presented. And so at the end of 2015, the Heart Association also came out with a statement on this very document, saying that they were recommitting to the teaching of not only advanced cardiac life support, but basic cardiac life support and pediatric life support. And so in 2015, there was a fairly significant kind of overhauling, and then they also kind of threw back the curtain and said, look, we're going to share with you on a year-by-year basis what we're looking at, what we're reviewing, and what we think this means. And instead of doing a broad spectrum year to year, they're going to do focused questions and look at the literature and do improvements a little bit more strategically and incrementally. So again, the message from that Institute of Medicine paper, that white paper, was really 6% of people out of the hospital are surviving cardiac arrests, and about 4 times that, but still only about a fourth of the patients who experience cardiac arrest inside a hospital live to leave the hospital. So again, it was that call to arms to commit more research and just really try to improve outcomes. And this is sort of that summative statement from their committee, that we need to build the nation's research infrastructure to give more support and accelerate some of the innovative work that was being looked at in terms of causes, treatments, and outcomes. So a really strong message. So let's look at here briefly, again, to kind of catch us all up, what was going on between 2015 and 2020. And I don't think it was well known. Again, people were used to and still used to looking at every 5 years getting caught up on ACLS and BLS, but there's actually published recommendations or updates to guidelines annually. And then they've reinstituted this 5-year culminating kind of review and reissuance. And so let's look at that. The annualized process, the review, is taken on by this International Liaison Committee on Resuscitation, ILCOR. And this information, this slide is on the handout if you have it. If not, it's obviously on the slide, or you can reach out to me if you need to locate it. But you can actually go to the side, see what the research questions are that they're looking at in the areas that they're looking at. It might be, as they've expanded their scope, they're looking at first aid questions, the benefit of use of tourniquets, or as we've seen the product of lately, the treatment of opioids and the implication of opioids in some of our cardiac arrests. So you can go to that page, you can see what questions are being looked at, and again, they're transparent about the evidence collection and review process. You can kind of see it over the course of the year as they come to conclusions, more formal conclusions, and offer it on to the Heart Association and other folks to take a look at. And so here's some things that have happened in the past years. One thing that they've done is that they've split the whole cardiac arrest scene, if you will, or context to in-hospital cardiac arrest and out-of-hospital cardiac arrest, finding that clearly there's some nuanced care and strategies in one environment versus the other that make it appropriate to split these out and focus more on the, like I said, the nuanced care. Not just the 5-year cycles, but this ongoing coordinated collaboration with the International Liaison Committee on Resuscitation. The focused review. In 2017, it was BLS and first aid. 2018, they issued some updates with post-resuscitative care for ACLS and PALS. They also committed to really going with standard kind of classic grade strategies of evidence evaluation, and have added a category for those things that are so new that there's not enough evidence to really come out conclusively either way. And then 2019, because of the research on feedback devices and improvement in overall cardiac and CPR, they came out with a requirement that they have that the CPR medicants had to have real-time feedback devices, and I think we've got a slide or two down the way we'll show that. And then again, this past year, 2020, in October, they did kind of a 5-year review and revising, kind of cleaned up everything, folded everything that had been introduced in the past 4 or 5 years and kind of reissued it, and also looked at how they reissue it. So it's in digital format. There's a lot more digital and alternate formats versus just the classic textbook. They're transparent. You can go and see this for yourself and go through it if you're wondering how they specifically manage the process, ILCOR primarily, and first forming the questions using this PICO or PICO-ST strategy, and then getting into the classification based on the strength of evidence and the quality of the evidence, the level of it, and coming up with their overall recommendation. So it's a very strong, very robust process, but obviously well respected. I think some of the challenges there are so many variables and so many confounding constraints right now that despite the 2015 utterance by the Institute of Medicine, I think we're still struggling to get any scalable resuscitation research anyway. And so this is sort of the embarrassment slide. Here in 2020, they've got nearly 500 recommendations that they're making in BLS and ACLS. But out of those, how many had the highest level of evidence, which is this level A, which is at least one high-quality randomized clinical trial, also then corroborated by a second random clinical trial or randomized clinical trial or a registry study? 6 out of 491 recommendations actually have that high level. There just isn't that much that's they would determine to be without a doubt free from bias or a large enough study, and so on. It's a continued, I'm sure, frustration and challenge. So, this is really the challenge of doing gold standard research is controlling for those variables, having a large enough population to study. It's pretty difficult to do prospectively for cardiac arrest. We can't ask people to volunteer. So obviously, pigs have become a focus for academic research, and I think we're getting better at resuscitating pigs. The question, of course, is, are we getting better at being able to transfer reliably that stuff to humans? And I guess that remains to be seen. And even, surprising challenge is just defining success or the terms and the measures you're using. So they've tried to come out with, and the Utstein criteria is not new, but they've kind of redoubled a commitment to that. The CARES registry, get with the guidelines. There's a number of innovations out there and initiatives to try to get people to be more consistent in how we measure our results, so that at least we're a little bit more closely aligned to comparing apples to apples and oranges to oranges. So the challenges here, in addition, in terms of the research, is, in addition to the practice itself, or the science, it's the physiology of resuscitation we're continuing to learn about. It's the technology in which we deliver the care, we monitor the care, we evaluate the care, that continues to change. And then even the way that we teach, that we can recall and we can access the information, the resources to deliver the care in an appropriate way. There's kind of like 3 spinning plates here in terms of research and development there's innovations in all 3 of those. So really, for those that, again, many years ago, we had a single source of truth that you could expect it to come out every 5 years. It seemed like it was pretty consistent. It's certainly more transparent, and it's clearer what we're trying to do. But I think that people continue to be, maybe even more so now, overwhelmed sometimes by the science for the lay consumer or the casual consumer of it, and just sometimes the complexity and the nuances of it. So we're going to try to kind of go through some of that. So let's look at the practical points, the updates. Let's start going through some of these updates in 2020. One of them that the Heart Association has put out. Again, it's got the in-hospital cardiac arrest chain of survival and the out-of-hospital cardiac arrest chain of survival. They've added a link, so there's a 6th link instead of 5, and the 6th one is recovery, and that is because there's been a lot of research and maybe more clarity and actually more complexity, more nuance to the recovery process, both just post-arrest, immediately post-cardiac arrest, which is this 5th link, but the 6th one is the longer-term survival and discharge from the hospital and return to some previous state of normalcy. So that has been added. Ventilations in the past were just recommended for adult that was in respiratory arrest to be 5 or 6. I'm not sure that there's compelling evidence. They're just trying to be clear and a little less equivocal. So they just gone to 6 seconds, one ventilation for every 6 seconds. So you still would, if you're doing the 30 and 2, 30 compressions and 2 ventilations for a person in cardiac arrest, you can do that. If you're going to do continuous compressions, which there's probably there's more people looking at that, then you just want to interpose that ventilation every 6 seconds. That's the recommendation. For tachycardia, they used to have in ACLS a number they used to put down So it would range up to 120 joules recommended for synchronized cardioversion. They've dropped the numbers here and just said that synchronized cardioversion should really it needs to maximize success at the first shock. Don't look at it as incremental shocks that are both traumatizing to the patient if they have any level of consciousness, but also potential injury, and just go with what would be a reliable, likely best first shock. So they certainly remind people to look at what your vendors say, because even if it says biphasic and two different people are using biphasic defibrillators, there are still different waveforms and nuances to that, so the recommendations may be different. So please reach out to whoever your monitor defibrillator manufacturer is. A couple of changes in medication, and here I'm in this slide, it's primarily patients with pulses, may not be breathing, might need some assistance in terms of circulatory support. So the meds I put on here, atropine is again no longer a range of 0.5 to 1, it's just 1 milligram. It's still repeated every 3 to 5 minutes. They've made kind of an express concession, if you will. I like to think of it as a concession that, when you say 3 to 5, sometimes when you say that fast, novices hear you say 35. And actually, when you look at doing 2-minute cycles of CPR, 4 minutes seems appropriate. So a lot of folks are just settling on and recommending 4 minutes, but anywhere between 3 and 5 minutes. And of course, atropine isn't necessarily in cardiac arrest, but they're just trying to be more consistent in the way that they're practicing administering things in peri-arrest and arrest. Dopamine got bumped up a little bit too. It used to be a range of 2 or 2.5 to 20 micrograms per kilogram, and they just opted and said, we're really going to see the effect, the chronotropic effect with 5 to 20 if it's going to be helpful. Then post-arrest for oxygen, usually it's in the 94 to 99% is our goal overall. They've just said an allowance for post-arrest, some of that instability is 92, 98 is a good range. And then lastly, on this slide, they came in and said, when you have an intravenous or intraosseous option for establishing medications and are providing medications, then IV is preferred, IO is still acceptable, but we may have gone overboard and said just because it's faster to go with IO, and I think they just feel like there's more evidence to support IV over a kind of a handful of possible problems in terms of placement and reliability, especially when you go below the waist with placement for medication administration. So, which is the most common is that just below the tibial plateau for the IO. Not that it couldn't be put in the shoulder, in some cases it's the sternum, but. So anyway, that's their recommendation for just in general. And then for cardiac arrest, excuse me. Now, sometimes this has been generalized, and you have to look at their literature to kind of get a little bit more specific. But epinephrine, there's been this love-hate relationship with epinephrine, where epinephrine, since the beginning, was looked at as this inotropic, chronotropic medication that will help you kind of jumpstart chemically the heart, and then evidence came out that our may have helped the heart, but it also led to some vasoconstriction in the brain, and in poor perfusion situations, maybe we're not doing such a great job with neuro outcomes, and I think they backed off from that as well, and they just come back to this. In general, there's not a priority for medications in ACLS. per se. It's still quality CPR. It's defibrillation if indicated. But they did say, epinephrine is kind of back in their good graces. And in particular for non-shockable rhythms where there isn't this need to really get things established and move to the shock, where the medication might be a distraction. They're saying in those non-shockable rhythms, start your CPR, start your line and give that epinephrine. And again, same mantra that you heard before, 3 to 5, it's still the repetition of the single milligram every 3 to 5 minutes. And again, to get into a cadence and to avoid confusion, it's often 4 minutes. Again, in those 2-minute cycles, it seems to reoccur in the same place and not catch people off guard as much. The other change came about with amiodarone and lidocaine. Amiodarone was the preferred medication for a handful of years, but now they've backed off and said either one. So amiodarone 300 milligrams initially, and then repeated in that 4-minute time frame, 3 to 5 minutes, 4-minute time frame. At half that initial dose, 150 milligrams, would be appropriate to the guidelines. Or you could go with lidocaine from 1 milligram to 1.5 milligrams per kilogram, and then repeat half of that dose in 3 to 5 minutes. So you can really choose between those, and they felt like both were efficacious. So they expanded the use of waveform or continuous capnography to apply it if you have the attachments to do it. If you're ventilating with just a bag valve mask versus an advanced airway. In other words, get that capnography on. It's an excellent tool to monitor CPR itself and then spontaneous return of circulation or ROSC. So it kind of got bumped up in terms of its breadth of use. And then there's some information on opiate-related overdoses, and there's a little bit about maternal cardiac arrest, where they've shared some updates on that. And honestly, in both those cases, it's still kind of straight down the middle as far as your standard approach. It's just being cognizant in the maternal arrest that the priority is to try to save the mother, and that if failing that, then you can transition to trying to save the fetus/infant. And then naloxone is actually the education on naloxone and its role in an algorithm is introduced in BLS, and then it's again recurs here. As something to consider if the circumstances indicate that opiates may be involved to help counteract some of the hypotension and things like that. There's some information shared again about right and left ventricular assist devices as they're becoming more prevalent and nuanced in how they present. You have to take a very different approach to that as well. It's kind of beyond the scope of what we can cover today, but they share that. And then in that recovery sixth ring, they spend more time on prognostication information. They have a diagram on that, kind of post-arrest, some care during that time. And I included that in the handout. I think there's a slide clip of that and more information, again, kind of beyond the time limit we've got here. And I want to go through this fairly quickly because, again, stroke, there's a lot of subject matter in ACLS, and I really wanted to, because of time, focus on cardiac arrest, but remind everybody that the treatment of stroke continues to evolve, so there's an updated algorithm there. There's more of a focus with EMS and going direct to CT and MRI. Again, it's trying to save time every way possible. Endovascular windows expanded from 6 to 24 hours. You can, really plan to use both alteplase and endovascular therapy. And then it's a typo. It says titrate O2 to greater than 94% for stroke patients. Then again, the reminder here about EMS arrivals, trying to fast track them to determine whether you have something that is treatable and within your scope for possible stroke patient. So let's talk a little bit about performance. So that's a little bit about some of the changes in the kind of the basic approach. In 2018, they provided the first ever educational statement and really finally kind of confessed that there really is no magic to every 2 years of recertification. I think they've always shared that there's significant drop off in skill and knowledge in 3 months to 6 months. So they've got some strategies. And I say there's a number of entities, so it's not just the Heart Association, to space out the learning. They in some cases, and Mary Greeley does that with basic life support, they've moved from certification to credentialing, where they've broken the entire set of competencies and knowledge content into parts and then space it over 2 years and then provided a means where people can do a little bit. So again, following this more frequent, shorter sessions. There's also been some work on the digital education and gamification. Some of that's gone now into some of the heart code and related formats, again, that some of the other vendors have done, where they're teaching you're not sitting in a traditional class. You can still sit through a traditional class, but you can also do these hybrid classes where most of the core concepts and all are presented online through these digital platforms. And then you even take your test there, and then you go somewhere to actually do the hands-on practical testing. And then they've developed apps for your phone and for your computer to do. If you don't do the formal credentialing, for example, you can actually just do some practical review, content review, and strategy review with a program like ACLS Booster. And again, there's a number of them out there, but I'm just again, identifying the different venues in which they're finding that education can be effective and retention helped in that. Then I mentioned before this University of San Diego platform, which again, this advanced resuscitation training program from San Diego is sort of interesting. We'll go to the slide there in a minute. But so the focus is on mastery learning, not just remembering and forgetting it, but being able to recall it. Low dose, high frequency is the goal, if you can. Use audio and visual feedback to really fine-tune your ability to provide high-performance CPR in an appropriate response, and then make it accessible. We're all busy, and find the platforms for that, and can you deliver that content within the context so it makes sense and it can be attached to previous learning. Here's a slide about this, and I'm not sure where else it's gone, but it really started with Dr. Davis out in University of California, San Diego. But ART, which is advanced resuscitation training, and then the BART, which is basic arrhythmia recognition training, they've seen some pretty significant results. But this is sort of like a culture thing they built. There's a single algorithm, and they've kind of folded in their rapid response, their peri-arrest rapid response team into kind of a continuum, and built this resuscitation culture. It's like I said, it's a single primary algorithm and then some pieces that attach to it. It's gotten a favorable review from like the Joint Commission and other folks. So we'll see where it goes, but gosh, look at their ICU arrest mortality has decreased by almost half. And from the financial standpoint, payouts have decreased very substantially, and just the expenditure for training seems like it's more cost effective. They front end invested in a lot in this out at their resuscitation center in developing it, and I think you can access it if you're just curious or interested by contacting them directly. Here's a quick slide of one of those ways you can deliver education on a cart. This is a quarterly RQI system. Again, there's other systems out there, but this one the Heart Association put together. You can do, it is available for ACLS as well. It's a subscription-based thing. They provide actually the cart and content, and people get issued these e-cards that are credentialed. They have to do things quarterly. So again, different strategy. Feedback devices. I want to point this out because the underpinning of quality CPR, of really successful, good outcomes in ACLS, if there are two things that are really proven through evidence strongly is high quality CPR and appropriate defibrillation. And up here in the upper right corner, minimizing the interruptions, creating this chest compression fraction, CCF, where you're on the chest doing compressions during an arrest, a patient's arrest for 80% of the time. 80% of the time compressions are being delivered. It's a depth of greater than just over 2 inches. You get complete recoil, so there's refilling in the thorax to deliver more pressure with the next compression. And then the right rate, and then the rotation, so you can keep that high quality up, are really important. And it's looking now like seconds count. So there's even for high performance CPR, this concept of hovering your hand. So if you're preparing to defibrillate a patient, the next person is going to take over CPR can actually be not in direct contact, but hovering over the patient so that the minute that the defibrillation's delivered, they begin the compressions. And we'll talk a little bit more about how we can save time and really be efficient in that 10 seconds. That's one of the focuses for increasing success, it looks like. This middle picture is at this hospital anyway. We use this type of a monitor defibrillator. In the center of it, the upper center, there is feedback, live feedback. If we're doing high quality compressions in terms of a rate and depth, if we're getting complete release, and the rate itself of those compressions, and here's the depth right over here. This is the little CPR metric, if you will, or collection of metrics that somebody can be monitoring to make sure that we're doing that high performance CPR throughout. Think of that as kind of like baking the cake, that everything else is frosting on the cake, but if we don't have it baked, we don't have the high performance stuff baked in, then we've either got an undercooked or not cooked cake, and everything else is clearly trouble. There are other devices, there's feedback devices for CPR itself that you can put on. They're independent of the monitor defibrillator that you can put on the chest, and it can keep you in terms of rate and depth in the acceptable range. And there's more parts to this. There are apps you can download on your phone for the rate itself. So there's a number of tools all being built to try to support this high performance or high quality CPR. Even in a lot of centers where you see more than really occasional or rare cardiac arrest, they develop a pit crew response, just like in the race cars, where they pit and they've got this crew that's trains all week to do this thing in fractions of a second, do their different jobs in fractions of a second. That level of efficiency is brought to advanced life support and basic life support, so people know where they need to go, what they need to do, what the quality measures are for their particular job, and how that fits together. And so again, if it's a significant part or a significant risk to your job, then it'd be good to pursue stuff like that. Okay, so here's a little bit more diving into some of the details. Conceptually, this seems to still be bearing out. This isn't heart association, this is basic cardiac arrest concepts, if you will, that the very first phase of cardiac arrest is probably electrical in the initial collapse, and an early electrical intervention, if it's going to work, needs to be provided in that early phase. Then you get more after that first 3-4 minutes into where you have some circulatory issues, where you could still shock the heart, but chemically, it's not going to be as receptive to picking up and continuing or recommencing effective circulation. So there, it's the CPR is definitely important there. And then we get into the metabolic phase at 10 minutes, where it gets really difficult because you're dealing a lot with the protracted bad chemistry that's going on that isn't going to make it helpful to get out either. So think about that and kind of the priorities as the arrest continues. And again, a reminder, when we say all this about high quality CPR, here's some images to kind of bring that to bear. Down here in the lower left, CPR, cardiac output without CPR, it's 100%. When you do CPR, it is a fraction. You don't have intact valves and, the kind of the ringing contraction of the heart. It's just a squeeze, simple squeeze. So you don't get nearly the output and the effectiveness. So even what we do isn't that great. We need to do what we can do the best we can. Over here, this is showing you coronary perfusion pressure and what's, beyond the technical issues here, just look at it and say, when you get compression started, it takes several compressions to get it pumped up to the adequate perfusion rate, and then continuous compressions will keep it there. The minute you stop to go give ventilations, for example, or do a pulse check or something, it drops, and then you have to build it back up again. So even though it looks like you're compressing here at the very beginning, and you are in fact compressing, you don't have adequate perfusion for maybe 6 to 9 compressions, and out of 30, we're starting to whittle away at that effective sustained perfusion. So some thoughts here about the significance of this and outcomes is what's captured in the lower right. And then, again, this one, probably the most important thing to take out of this slide is just at the very top, and that is 80% or greater of your time spent in arrest needs to have somebody on the chest doing and being monitored for high quality CPR. You still layer things on top of that, but this is where the focus is getting that and sustaining that. People get distracted and suddenly they're ventilating at the same rate that they're compressing the patient. For those that don't do it regularly and in a disciplined fashion, they're just distracted by that separate cadence. And it's also interesting that in retrospect, a lot of folks believe they're on the chest a lot more than they actually are. So again, that's why monitors, and whether they're human monitors or it's technology, is monitoring an overall arrest. You can go back and you can look at it and see what your CCF is on that, and whether it was this 80% or higher, which is high quality, or less than that. And obviously, spontaneous return of pulse, there's some mitigating circumstances, but this should be the goal, is 80% or higher. So this is another development in ACLS in a code, the mega code, is they want you to assign the role of a CPR coach. And, for most of us, we're probably thinking one more person in the room is probably one too many, if there's not already too many. So this is, if there is an additional person, then I think people are looking at the individual that's running the monitor as a person that might be able to also then monitor the CPR and make sure that it's high quality. Any adjustments in the height of the bed or the step stool, or the movement of the patient laterally to better accommodate the CPR is important. They found that straddling the patient on moving carts, trying to do CPR while they're moving is ineffective. You just have to really work at proper body position and getting all those other mechanics. And again, that's the use of those feedback devices to help you recognize that. The electrical piece. So here's where you can fine tune your ACLS, and they're coming out with some language that kind of supports that. So the length of the pre-shock pause. So this is when you stop. After 2 minutes of CPR, you stop. You reevaluate whether they have a pulse or not, whether the rhythm is appropriate to shock. You clear everybody and then deliver the shock. That period, that pre-shock period, the longer it is, it appears the worse the outcome. And what they're summarizing here is every 5 seconds of delay probably cuts in half the likelihood of successful defibrillation. And this kind of, here's a slide that shows that 3 seconds or less, there looks like they're getting close to 100%. 10 seconds, you're getting about 80% successful conversion with the defibrillator, and you start to get out beyond about 15%. Now, a lot of current like AEDs, because of safety factors, are in the 10-second range. So they're already pushing it. And again, remember what we said about effective compression. So in the previous iteration of ACLS, if you did 30 compressions, you pause, now your perfusion pressure goes to 0, you check for a pulse, say 5 seconds, and then you're gonna charge up, for safety reasons, you're gonna then charge up your defibrillator, so you have somebody resume CPR. Those compressions aren't perfusing. Remember, they're starting to build it up. So actually by the time they get to the point where they've built up maybe the first compression that's adequately creating that coronary perfusion, you actually have them stop again and deliver the shock. So where I think people are leaning now, and ACLS is suggesting, is charge the defibrillator during the last few compressions of your 2-minute cycle. Have it charged and ready to go. So obviously this means that the person has to be a little more safety aware that's going to be managing your defibrillator, but be ready with that. And then actually you don't have to check for a pulse if the shockable rhythm hasn't changed from the last 2 minutes ago. You can just go ahead and confirm that that's the same rhythm and shock it. Or you can electively check for the pulse, and actually your person that does your ventilations, they're done when you're doing the last 30 compressions. There is no 2 ventilations and then shock. They're just done. So they're done 30 compressions early and can palpate for the pulse and be on it, and that's being created by CPR. Then clear the chest to look at the rhythm. At the same time, you're getting their feedback on the pulse, and you can get closer to this 3 to 5 second range still safely. It's just making sure that people are prepared for it. So another slide looking at the same concept. And another reason why people are looking at, as an alternative, continuous compressions and interposing the ventilations to try to sustain that coronary perfusion pressure. And then this is a slide that just goes through what I just explained, where you do your 2 minutes, you pause to do your pulse check, then you're starting the compressions again while you get ready to charge, and then deliver this. There are new defibrillators that actually see through the artifact of CPR. You don't have to pause to check the rhythm. You can actually see it on an ongoing basis. So what you don't want to be is the weakest link. You want to, as again, keeping with my getting peace of mind, is plenty of proper prior planning and perfect practice will prevent the poor professional performance. And so I've mentioned the pit crew concept. Here's a different way of looking at it. Here's my suggestion, especially for the infrequent user of ACLS, that this might help you conceptually. Still the same general concept. It's still the same science. I'm not changing that at all. So if you're not in the proficient expert or maybe competent and want to look at it differently, consider this. This is the traditional way. And by the way, I show you this slide for 2 reasons. One, this is the adult cardiac arrest algorithm. It's copyrighted by the Heart Association, so you can have access to that online. Be very careful what you get, because this one, with the exception of what I typed on it, looks very similar, and it's really a satire version of it. So hurriedly taking something from the internet and trying to study it without confirming that it's the Heart Associations could lead you down a wrong path. But they have that shockable route, and then the non-shockable rhythm, epinephrine put in here early, and because you don't shock them, right? So here's my suggestion for you to consider, preloading this concept, this mind map for you. It's based on those 2-minute intervals and the sets of 30 compressions. And we want to spread out the tasks. So what I'm not sure is very clear in current ACLS, so this is just my recommendation. You don't have to follow it, but when they give you all the IV, all these things to do, people have a sense that you need to start them all at once. And it's really, how about layering them in? So I think this will help. And so just think of it as a track, a 2-minute track. And starting here at 0, there's going to be the first 30 compressions, and the team, the most of the team needs to focus on just the fact that we're accommodating high quality CPR. Do what you can to make sure that they're doing and continuing high quality CPR, and that the compressor says at the end of each set of 30, one set completed, or first set completed in this case, because that'll help you keep track of where you're at in this 2-minute cycle. The second set of compressions, now that you've established that they're doing good CPR and your CPR coach will continue to monitor them, then you can start looking at what's the underlying cause, where are we at, what have you already done with this patient, and again, the person doing compressions needs to say out loud, second set completed when they're done with 30. So you have a first set where you're focused on the BLS. The second and third set, you can kind of talk about strategy. We've got 2 minutes. What do we want to accomplish in this 2 minutes? How about this first 2 minutes? Let's look at getting defibrillation, and then some of you are assigned roles and start preparing things. Get the IV ready, or a better IV ready, but don't everybody jump in there and cause us to delay the priorities of defibrillation. So you get into the second and third sets where, again, they're counting out loud. The fourth set completed, and you're in the last set. During the third set, so between the third and fourth set in here, you're assigning roles. You're saying, hey, Paul, I'd like you to take over compressions next time. We're going to be charged and ready to defibrillate at the end of these compressions, so everybody pay attention. Then that fifth set of compressions, which should put you getting close to 2 minutes, you tell everybody, or remind everybody that this is the last set. The ventilator can then move down and check for the pulse, because they're not going to do another ventilation, and charge the defibrillator, and then the compressor counts out loud the last compressions, 24, 25, 26. This gets everybody an idea of where they're at, 27, 28, 29, 30. Look at the monitor, it's shockable rhythm, you're already charged, they've checked the pulse. You just ask them, is there a pulse? No, step back. Let's shock the patient, shock delivered, and then you go back to compressions. Again, on your your next set of 2, the first thing you focus on is high quality CPR for that first set. Now, it doesn't mean other team members can't be doing things, but this is the team priority. So if you need additional resources, whoever is going to take over compressions is struggling, this is the priority. This is also where you can start thinking, after you've defibrillated, you've looked at the monitor, whether you need to give a medication that's appropriate to that, like amiodarone for refractory VFib or epinephrine. And then because you're doing this 2-minute cycle, you'll know about when you're going to be doing that again, instead of offsetting it with 3 minutes. So that's my thought. Now, what I want to finish up with is just talking about or looking at some other things that are pretty exciting that will help to support ACLS, if you will. One of them is, again, I said good BLS. Despite the gains, the general prevalence of AEDs, less than 40% of adults receive lay CPR that arrest out of hospital, and fewer than 12% have that AED applied. And this I just put up here as an example. AEDs come in all shapes and sizes. You don't have to be certified to use them. They all work on the premise that you push some button on them to start it up, and it will indicate by voice and sometimes by screen the steps that you need to take, and just follow the AED. And this lime green one, for example, is the one our hospital uses, and it has a CPR feedback device built into it as well. So the lay public or a member, the staff member that's maybe not as proficient in CPR can get good coaching while they're doing it. This slide is, in the past couple of years, they're talking about, because we don't get CPR started in the field or out of hospital, let's look at telephone CPR. And they're starting to get some pretty good data, and they're supporting it. It's better than no CPR at all. So that's a reference there. And interestingly enough, now they're putting it together and saying, with your dispatchers, your telecommunicators, when somebody calls and it's a member of the public and you're trying to coach them through CPR, there's also free software that you can load at your dispatch centers and have volunteers register to be available to provide CPR, and it can show in real time, based on enrolling your phone, whether you're in an area where you can help respond. And so they've got some, they also have a mapping software now for AEDs that are registered. So the community's going to have a better network. This is really exciting. I don't know if you guys have heard about this, but here in Iowa, we just got $10 million grant from Helmsley, the Helmsley folks, and they're going to put an AED, high-end AED in every law enforcement vehicle in our state. And they're going to ask law enforcement that currently has AEDs to donate those to their community or somebody else within their infrastructure. And so this grant will provide AEDs that are capable of being tracked, that have GPS built into them. And so we'll see. That was just announced this a couple of weeks ago here, February, March of 2021. It's a 3-year program, and it's pretty exciting to try to get more of those out there. This is something that's been out there. It's kind of high visibility. Still not clear whether these are effective. And I think some of the questions about their effectiveness is the ability, just like defibrillation, to put them on with minimal interruptions in CPR. And so they have these retracting bands that do compressions. They have piston devices that do it. They have handheld ones that have an adaptation here that actually a suction cup, glorified suction cup that holds the chest and does active compression, decompression. In fact, out of all these devices, this is the only one that's FDA approved specifically for cardiac resuscitation, but they're all out there and being used. This is one of the newest ones. It's an elevation over a 2-minute period of time, head elevation, which reduces cerebral congestion, but at a slow enough rate and a low enough elevation that you can still perfuse the head. They're potentially seeing better outcomes. So these are out there. Again, a Helmsley grant got several $1 million, got these in Iowa. So you can see a lot of these Lucas devices or the Auto Pulse or possibly the Eligard. And I'm just, because you might hear the name, again, I'm not supporting these specifically. I'm just identifying some of the items that are out there. And that just helps to explain that active compression, decompression. And there's even questions about some of our basics, our fundamentals, pulse checks. Are pulse checks in cardiac arrest really effective? Do healthcare workers, can we really detect faint pulses? So this is some work with ultrasound use in cardiac arrest. Hopefully you all have the handout. It's up to us to save the world, and ACLS is trying to establish kind of a baseline for it. So that is my presentation. Got a couple of minutes left. I'm not sure, Tim, I think I've gone full screen, so I don't see any questions, but I have contact information there. I think they're going to make the PowerPoint available to you. You have the handout. If you need more information, please let me know. One question that sometimes comes up in cardiac arrest is what happened to all the meds and medications. You know, we had vasopressin, we've got a number of different medications that have been tried in recent years. And again, having, from an ACLS perspective, a wide enough, clear enough, sound enough study in more than one location has just been either confounding or a constraint. So from a general recommendation standpoint, there are fairly few medications, and most of them are close to being called more distractors, that people tend to look at the medication as the key, because that's the higher end delivery aspect of medical care. But it's actually more likely just that high quality CPR if indicated, and defibrillation also if indicated. So medications may be helpful, but doing that high quality basic work is probably most important. Communicate with your team, debrief afterwards, so that you can improve, and you can also decompress for people that may have questions or issues or challenges, and improve as a resuscitator, if you will.